In part 1, Dr. J. Reznick demonstrates how he looks at 3D volumes in his practice. In our Vision X software, he demonstrates how he looks at the coronal view, the sagittal view, and the axial view. If you missed that, please watch part 1. We then discussed how our software optimizes the panoramic curve automatically and maps out the inferior alveolar canal using AI. This is a huge time savings for the doctor. In this video, Dr. J. Reznick will share how he plans for an implant using our integrated surgical guide solution. Enjoy the video. I hope this is helpful to you.
Yeah, this is the software that I use for my practice and my implant planning.
So at this point, it's loading up the DICOM automatically without having to export, import, any of that stuff. I have the STL right here.
Okay.
Now, this one is not in SSI. I do have SSI files.
Okay.
Let me look. Let me see which case this is again.
Okay.
This one is 1025. So let me look for 1025. Maxilla, mandible, doesn't matter to you. Let's do...
No.
Okay. I'm going to just bring in this. I changed the patient's name, so it's going to give me this. At this point, let me... You're so familiar with this. I'm going to go ahead and give you control. It'll make it so much easier for you.
Okay. All right. So what you're going to do is you're going to correlate sites or correlate locations between the two scans. Let's see, I'm having trouble rotating. There we go. So, for example, I'm going to say that this first molar here is the same as that first molar there. Maybe this, let's see, let's do this canine. That's always a good tooth to do. Canine is the same as the canine. Rotate it around. Let's see, this lateral incisor here corresponds to that lateral incisor there. And then, and I tend to do usually 4 points. First molar here, first molar here.
Now, does it matter that it has scatter? Is that an issue?
Not really.
Okay.
Not really unless it does. So it doesn't matter unless it does. So if it doesn't line up correctly, and of course we're going to go hit next. And let it do its magic. If it doesn't look like it's lined up properly, then I'm going to go back and I'm going to maybe add an additional point or pick another point or two. So as I scroll around, now it looks like it's pretty well laid on pretty well. Now here you see it looks like the restoration goes beyond the optical scan, but that actually is just artifact.
Okay.
That has to do with some of the beam hardening and edge artifact that we see with CBCT.
Okay. So
that actually looks pretty good. And here where the gaps are, that's of course where the porcelain is on the crown. So that looks pretty good. So I'm going to go ahead and click Finish. And now I've got my CBCT that has my CAD-CAM integrated into it, so I can use this now for my fine-tuned treatment planning. And I'm just going to go ahead, I'm going to go back here, and I'm going to adjust my panoramic curve.
This one does not have the CEREC crown. However, we could bring in the SSI for you for that. Let me minimize our picture real quick, if you don't mind, real quick. I just want to minimize this so people can see what you're doing.
Okay.
There we go. Go ahead. So this one does not have an SSI crown from the CEREC, but we can bring that in. How important is that?
Well, for the final treatment planning, I want to know exactly where my final prosthesis, or approximately where my final prosthesis is going to go. This is for treatment planning for the implant. It's not planning the final restoration.
Okay.
So it doesn't have to be exactly perfect, but you want to have as good an idea as you can of the size, the dimensions and the location of that final crown, because you want to be able to place the implant so that it is centered under that restoration, and the emergence profile of the screw access hole is going to be in the center of your restoration, so that restoration is made easier. You
Okay.
don't want something that you don't want it to be off to one side. You don't want it to be, more lingual, more buccal. You want to try to be as centered as possible to facilitate construction of the prosthesis.
Okay. With an SSI file that contains the crown, with an STL, can you still make a proper surgical guide without the crown?
Yeah, you don't need the crown. You just need to be able to, although, let's see, I guess you can still upload your order. You can't import the SSI unless it has a crown, or you can't export the SSI out of CEREC unless you've made a crown.
Sure. Okay.
But you can import that into the implant planning software. And the important thing is that you have the STL file of the surface of your dental surface of your teeth. So that's the critical thing, because that's going to be the intaglio surface of your surgical guide. So that you have to have.
That makes sense. At this point, what would you do after you adjusted the curve?
Okay, so now I'm looking to place my implants. Let's see, was there a space on the upper right?
I think there is.
Is that where you're going to go?
Yeah, there's one up there.
Yeah, it's kind of a skinny space. So then what I'm going to do is I'm going to go over to planning.
Okay.
And I'm going to select an implant. And let's see what we've got here. So this is going to be, I guess, for number 4. And let's do a 4.2 by 11 is kind of my default size.
Do you have an implant that you prefer today?
I'm sorry, do I have what?
Do you have a specific implant you use?
I use the OsseoSpeed EV. I use the Nobel, the conical connection. Those are kind of my two most common.
Okay.
I use the BioHorizons implant. Occasionally Straumann, but not all that often.
Okay.
But basically, the Astra and the Nobel are my most common. So I'm going to drag this over and click. So it should. Okay, so now I'm going to click over to implant aligned, and that's going to show me the implant, or the image centered around the implant. So now I'm going to move the implant into the center of the ridge.
Okay.
I'm going to try to align it angle-wise with the adjacent teeth. And that looks like it's fairly centered in the ridge here. Okay, so now, actually, let me see if I can put my sleeve. Let's put in the sleeve too, because we have to make sure there's enough space for the sleeve. So the surgical guide, let's do a digital guide. Those are the ones that I can print in the office.
And that's what you currently do, right? You print your own surgical guides.
Yeah, that's what I do.
Okay.
So we want to make sure there's enough room here for the sleeve to fit. So it looks like kind of a tight space. Yeah, so when you see, so it looks like, let me see if I can enlarge that a little bit. So it looks like there is not quite enough space for the sleeve to fit.
Okay.
So that leaves us two options. One is we trim the adjacent teeth to allow room for the sleeve to fit.
Okay.
And the other is to use a narrower sleeve. So with this sleeve, we're placing the implant fully guided. So in other words, we're drilling through the guide all the way up to the final drill. Whereas if we don't have enough room for the sleeve, one of the options is to use a narrower sleeve where we drill partially fully guided, and then generally the final osteotomy we drill freehand.
Got it. That's usually called a pilot sleeve, am I correct? Or
it can be a pilot sleeve, or it can be up to, let's say, the like the second drill. Okay. So the pilot drill and maybe the first or second drill goes through the sleeve, and then your final diameter you enlarge through freehand through freehand drilling. So in a case like this, what I'd prefer to do is I'd actually like to trim the adjacent teeth. I'd like to modify the adjacent teeth to give room for the sleeve. And my rationale for that is that if I've got a narrow space like this, I don't have a whole lot of room for a nice emergence profile of the abutment and final restoration. Because it looks like this distal tooth has drifted mesially. And that's closed in some of our space. Okay, and maybe this is drifted a little bit distally.
Mm-hmm.
And so you want to have a smooth, emergence profile for your final restoration. So rather than drilling with a narrower sleeve and then hand drilling, I want to make sure I have enough room to get a proper abutment in there and have a good emergence profile for my restoration. So once I kind of plan where the implant's going to go, we're going to take a look at my implant length. And obviously, this implant is too long for this space.
Okay.
So you've got a couple options. One would be to go here and shorten the implant, and the shortest implant in this line is an 8 millimeter. And if we look at that and we see we're a little bit super gingival on the lingual, so let's go a hair up. All right. So when I do that, use the shortest implant in a 4.2.
Okay.
Okay. Then you can see that we protrude a little bit into the sinus.
Mm-hmm.
So it looks like you can engage this floor of the sinus bone, and that would certainly be acceptable. Another option would be to plan on a longer implant and do an indirect sinus lift at the time of implant placement.
Okay.
Which is generally what I'll prefer to do. I'll do a sinus lift, augment a little bit of bone here, and then place the longer implant. Now, if this space was even thinner, though, what I would do is I'd go with a narrower implant to begin with. So not a 4.2, which is kind of the standard implant size for premolar, but I might go down to, whoops, wrong button. I might go down to a 3.6, which is a narrower implant. That's going to give me a better emergence profile. But we're going to have the same dilemma, and that is the 3.6 uses the same sleeve as the 4.2.
Got it.
So we're going to have to, unless we want to just do a pilot drill and which is kind of for a 3 millimeter implant, and we just have our pilot drill. If we want to place a 3.6 or a 4.2, we want to accommodate enough interproximal space for our sleeve. So since we've got enough space between the roots, right, between the implant and the adjacent teeth, you want to have at least 1.5 millimeters between the implant and the adjacent teeth. And this border around the implants looks like it's probably about 1.5 millimeters.
We could check that real quick.
We can check that. Let's see. Yep. That should be, I think, under here.
That's correct.
And general, let's see, was it? Let's see.
It may be under safety margins up here. You're in the right spot.
Oh, safety margins. There we go. Okay, so yeah, 1.5 at lateral distance and 2 millimeters apical distance. All right, so let's close that. So that means we're at least 1.5 millimeters, so more like 2.5 millimeters away from this molar number 3 and then number 5. So we've got enough room mesiodistally. Buccolingually, we also want to have at least 1.5 millimeters, if not 2 millimeters of bone on the buccal and the lingual or palatal aspect. So we could actually go a little bit more palatally, and that's still gonna keep us fairly well centered on where the restoration is gonna go.
Got it.
And then we're gonna be a little bit more solid bone. So we're gonna be a little bit more centered on the ridge. And just adjust my angle a little bit there. So again, I would do an indirect sinus lift and place, in this case, a 4.2 by 11 millimeter implant. Because even if I place the shortest implant, which is an 8, I'm still going to be entering into the sinus.
Okay. You plan this chairside with your patient?
Yeah, I do this chairside with the patient, so they actually are watching and they can see. So for example, this patient can see that they're going to need a sinus lift, because I show them, look, even with the shortest implant, we're still going to be, the ridge is still fairly narrow. So I think what we need to do is augment the ridge, and you can see, because we don't want the implant, the implant doesn't do any good if it's sitting in the air of the sinus. We want to have bone surrounding the implant. So this allows the patient to really visualize what's going through my head so that they can understand, what the treatment plan is and why we're going to do things the way we're going to do. So this is a really great teaching tool to educate our patients as far as what our treatment plan is, and to get them to understand why. And I found when you have a patient who's educated, they just do a lot better. They have an easier recovery, they have better long-term success, And so it's, this is in addition to a tool that I use for planning my implants, and then of course making my surgical guide so I get very accurate, efficient implant placement. But I get a more educated patient at the same time using the software.
That's great. Since you print your own surgical guides, do you mind showing us the process from here? How do you do that, and what do you use? I don't mind
Sure.
talking about that.
Okay, so what we're going to do then is going to go to treat. Go to treat. And there's two things we can do under treat. One is to generate a planning report. And what I'll do is I'll print out a planning report. Even though our office is paperless, I'm still old school. I like paper. So this is going to go now to my back office along with a treatment flow sheet.
Okay.
That's going to tell them exactly where who the referral is, where the implant sites, what size implants they need to order, and then what healing abutments or cover screws they need to order for the case also. So I'll print this out, and this shows an overview. If you're doing multiple implants, you can see here, if we're doing like implant at, let's say, 4, 5, and 6, you'd see 3 cross-sectional images, and then you'd have an individual page for each implant. And the other thing I'll do is I'll look at this and just verify that everything looks normal. I don't see any funky angles, or nothing looks out of the ordinary. So this implant placement looks good. And I'll go ahead and I will print out this for my surgical staff. So
Okay.
close that. Now, the way that we order the surgical guide is